Alrighty.
Good afternoon, everyone. My name is Dr. Brad Ray. I'm the Director of the Center for Behavioral Health and Justice at Wayne State University. And I'd like to welcome you all to our presentation today, which is titled Medications to Treat Opioid Use Disorder in Criminal Legal Systems. It's my pleasure to introduce our presenter, Dr. Deborah A. Peinels. Dr. Peinels is the Chief Director of Behavioral Health and Forensic Programs for the Michigan Department of Health and Human Services and on faculty at the University of Michigan Medical School, where she is Director of the program in Psychiatry, Law, and Ethics. She is also an adjunct clinical professor at the University of Michigan Law School. Dr. Peinels is the current chair of the American Psychiatric Association Council on Psychiatry and Law and is a board certified in psychiatry, forensic psychiatry, and addiction medicine. She has been a clinical psychiatrist in community mental health settings, forensics and correctional settings, emergency rooms, and court clinics. Dr. Peinels has taught medical professionals as well as those in criminal legal systems, including attorneys, judges, and law enforcement. Furthermore, she has spearheaded the development of police mental health partnerships and trainings and developed protocols and clinical services for treatment courts. For example, Dr. Peinels is co-developer of the Mission Criminal Justice, a model of wraparound services that provide support and aim to reduce recidivism for justice-involved individuals with co-occurring mental illness and substance use disorders and trauma histories. She has been a policy advisor and consultant in Michigan and elsewhere pertaining to the opioid crisis and opportunities to develop strategies to overcome it. I would like to thank Dr. Peinels on behalf of the Center for Behavioral Health and Justice, as well as our community partners for joining us today and presenting to us this afternoon. Thank you very much, Dr. Peinels.
Great. Thank you very much. It's a pleasure to be here and see people that have signed in. And this will be a recorded webinar, so you can share it with your colleagues once the link is made available. We're going to start by just going over what the agenda is, and I'll just need the slide advanced.
Just the arrow keys.
It's not working. 1 second. Okay, perfect. Thank you. So I'm going to go over the agenda for today. We already had the welcome and introductions. I'm going to talk about the neurobiology of addiction and opioid use disorder. Then I'm going to talk about opioid use disorder in the criminal legal system, prevalence and risks. I'm going to cover evidence-based treatment for opioid use disorder, including elements of treatment, terminology, and available medications, and then frequently asked questions about medications for opioid use disorder that is sometimes abbreviated as MOUD, M-O-U-D, how they work, pros and cons, effectiveness, and everything else, hopefully, that you would want to know about these medications. And then we're going to have time for question and answer and wrap up with a what's next. And again, this webinar is being recorded. All right, so let's start with the neurobiology of addiction related in particular to opioid use disorder. So whenever we talk about the neurobiology of addiction, we always have to start with pictures of the brain that can be complicated to look at, but I'm going to try and explain a little bit about what's happening. There has, for many, many years, been this debate about what is addiction. Is it willful behavior? Is it a brain disease? We are learning more and more about what happens to the brain when somebody develops an addiction. And we do consider it a chronic brain disease, and that although the first use of a substance might be a choice, it might be prescribed, it might be something that people aren't aware of, could have impact. Once the addiction begins, it does not become a willful choice. Addiction takes over parts of the brain that are involved with a judgment and behavior. So for example, what we call the prefrontal cortex and the limbic system, those are the parts of the brain that involve kind of the brakes on our behavior, as well as our emotional state. And these are where many of our life-sustaining functions are governed. And so once somebody develops an opioid use disorder, we can actually see changes in what the brain looks like in terms of where blood and where metabolism happens within the brain. That's where we see activity within the brain. And you can see in a healthy brain where on this slide on the left, you can see on a healthy brain what looks like normal functioning. And then in the brain of an individual who has some type of addiction, you can see many more of those areas are sort of not as activated. And we can also see structurally, not just in terms of blood flow. The picture on the left depicts kind of blood flow and metabolism. What we see on the right is actual structural changes that happen in the brain. You can see the brain on the right is a little bit more shriveled and it's a little bit less healthy looking. And that's what we call atrophy. And so these neurobiological changes include this atrophy or shriveling of the brain tissue and interference with what's called the reward pathway. And this becomes more pronounced over time. And the combination of what's happening functionally and structurally reinforces these addictive and self-destructive behaviors. So what does that mean? So when the reward pathway is activated, it impacts our motivation, behavior control, learning, and memory. And reward pathways are activated through all sorts of activities. They can be activated by food, they can be activated by sex, they can be activated by certain substances, including substances that people can develop a use disorder related to. So with the initial use of opioids, there's going to be often a sense of intense pleasure. And that's a positive reward feeling and even reduced pain. And that can be within seconds to minutes, depending on the route of administration. However, what happens over time as we're learning more about these brain pathways is that over time, instead of having this positive reward, this outpouring of the neurotransmitters that create that pleasure sensation, people end up experiencing decreased ability to feel pleasure from normal activities. And then what ends up happening is they may take more of the substance to feel that pleasure again. And then ultimately what's happening is they feel not only the absence of the pleasure, but they feel the down spiral of not having that pleasure. And so instead of trying to achieve that reward, they're trying to avoid the pain of not having a normal sensation. I can go to the next slide. And so that's why people, once they have these disorders, have a very difficult time stopping use because of this negative reinforcement, where they have a depleted state that results in what we call dysphoria or intense sadness and or cravings to continue to use, and that reinforces the use of more and more drugs. And dopamine is what we call the neurotransmitter. That's the chemical in the brain that we're talking about that usually is involved in pleasurable feelings. When it's released into the brain, that's where we usually, again, get a pleasurable sensation. But what happens is the brain chemistry changes. And so the way the dopamine is picked up in the brain essentially downregulates. And so the individual is trying to get more and more avoidance of the painful sensation of not having that pleasure or even that normal feeling anymore. And so the immediacy of relief overwhelms the disincentive for future negative consequences. And this is why we see individuals with opioid use disorder engaging in unbelievable behaviors that if their brain was functioning normally, they would say is not something that they would ever do. Judgment becomes impaired. They getting involved in high-risk behaviors. They might sell their bodies in ways that's very traumatizing, or other things that are going on. And to somebody who's not suffering from the disease, they might say, why are they doing this? Can't they just stop? But it's this tension reduction hypothesis that keeps happening. And so what we need to combat opioid use disorder are both medications, and we'll talk a lot about that, but also positive alternatives, and then time, because what we essentially need is to buy time without the negative consequences of substance use disorder to literally reshape brain activity to help people achieve recovery. So what do we know about opioid use disorder and the criminal legal system? Let's talk a little bit about that. Well, unfortunately, many people with substance use disorder find their way into the criminal legal system. And there's lots of reasons for that. we know that a large proportion of individuals who are arrested would test positive on a drug screen at the time of their arrest. We also know that individuals who are seeking to deal with what's happening with their brain may engage in behavior that involves illegal use of substances, and because they're illegal, arrests can occur. And one of the things that we see too is that once an individual with opioid use disorder is incarcerated, there's a hugely increased risk for negative outcomes. And part of the problem that we have in our society that I think we're trying to change over time is that what happens within the walls of incarceration in terms of treatment and access to care is different than what happens outside the walls of a jail or a prison. And the studies that are coming out, including one that was recently published in the American Journal of Public Health, showed that within 3 months of release, 75% of formerly incarcerated individuals with an opioid use disorder will relapse on their opioid use. And within 1 year, 40 to 50% will be arrested for a new crime. And what's even more concerning is their death rates go way up after incarceration. The risk of opioid overdose, that's the OOD acronym, opioid overdose, for former prison inmates in this study out of North Carolina was 40 times higher at 2 weeks post-release and 11 times higher at 1 year post-release compared to the general population. There's many risk factors that are associated with that, including being older, male, white, with more than 2 prison terms, and having received in-prison mental health and substance use treatment, which means that people with co-occurring disorders are especially at risk. And there's more to learn about this data for sure, because there's so much complexity to the whole issues of racial and ethnic disparities within the criminal justice system. And so we need to study this population more and understand more about prevention strategies. But so not only are people with opioid use disorder at more risk for getting into the criminal justice system, they're at more risk for bad outcomes in coming out of the criminal justice system. So let's talk about some evidence-based treatments for opioid use disorder and the elements of treatment. So in the big picture for opioid use disorder, we have treatment goals. Treatment goals include initiating long-term recovery, which often will include medication. Now, many people are hearing about medication-assisted treatment. We are talking about medications specifically targeted for opioid use disorder. And when you hear the phrase MAT, sometimes that's used interchangeably with medication for opioid use disorder. But medication-assisted therapy also implies that there's things beyond medication that include counseling, for example. So in this presentation, counseling is hugely important and evidence-based, but we're not really focused as much on counseling for the purpose of this particular presentation. So we want to, in the big picture, reduce the risk of relapse, overdose, and death. And by the way, when we talk about overdose, there's fatal overdose that obviously leads to death, and then there's non-fatal overdose. So in the big picture, we want to reduce relapse and all overdose, as well as death. We also want to reduce harms associated with use. We'll talk about that, but including things like infectious diseases, exposure to traumatizing situations, a whole host of other harms that come with use. We want to reduce the symptoms of opioid use disorder that can be debilitating or really impairing. And we want to improve people's physical and psychological health and well-being and help people learn coping skills because of this being a chronic illness that people will have to learn to live with throughout their lifetime. And we want to keep in mind the big picture of hope. That's a really important big picture point, that people can recover. They do recover. They go on and live very successful lives. And we want to make sure that that message is loud and clear. So again, in terms of the elements of treatment, medication is one piece. There's also psychosocial supports and behavioral strategies. There's self-help and mutual aid. And then there's recovery-oriented and pro-social behaviors that all can combine together to help people on their recovery journey. Okay, so again, for this webinar focused on medications, the term MOUD, or medications for opioid use disorder, is specific to medications. And these are medications that have been identified through research as targeted to treat opioid use disorder. They can be kind of confusing because some of the medications, well, all of the medications actually interact in some way or another with what we call the neuroreceptors involved in the pleasure and reward pathways of opioid use. And I'll talk about how they work differently in those receptors. It's a little complicated from a kind of chemical standpoint, but I think it's important to understand what these medications do. These medications are the most effective evidence-based treatment to prevent opioid craving, relapse, and overdose that we know of scientifically today. Again, for MOUD versus MAT, medication-assisted treatment, that implies that medicines are only there to assist other types of treatment. We don't talk about medications for other diseases this way. So some people have started to move away from MAT and talk more about MOUD, but I think both work interchangeably as long as we understand that we're not talking about medications as assisting other types of treatment. We're talking about medications that are needed. So for example, if I go to the doctor with a sore throat and I need an antibiotic to treat my sore throat, I might also need other things, like I might need ice cream. I might need to rest and sleep. I might need other kinds of supports, but I'll also need those antibiotics. And without the antibiotics, it's possible that if that particular sore throat needs antibiotics, because not all sore throats do need antibiotics, so it's not a perfect analogy, then those medications are going to be necessary. Medications for opioid use disorder generally are 3 types. And what happens with medications is you have companies that manufacture the medications, and they are first marketed under brand names, and then they become generic. And so usually when we talk about medications, we talk about their generic chemical name, even though there's brand names that are used that are marketing these medications when they first are introduced into the field after scientific and science and research shows that they can be approved by the Food and Drug Administration. So the 3 medications are Methadone, Buprenorphine, and Naltrexone. Buprenorphine is marketed as Suboxone, Zubsolv, or Sublocade. And then there's Naltrexone, Vivitrol, which comes in both an extended release and a pill form. And so the diagnosis and use of medications is done through appropriate clinical assessment and determination, along with the patient who has to determine for themselves what they want for their own recovery. And person-centered care is a very important part of helping people to achieve recovery. So what are some facts? We're going to talk about how does each medication work, what are the pros and cons of the medications, eligibility criteria, considerations, effectiveness, potential side effects, what are some interactions with other substances, are there guidelines on the length of taking medications or discontinuing them, what are some common barriers to these medications, and how can I help address them to ensure access, how can providers or parole agents monitor for illicit use of these medications. So again, here are the 3 main types in the columns: Methadone, Buprenorphine, and Naltrexone. They come in different formulations. Methadone for opioid use disorder is an oral liquid taken by mouth. It's got brand names called Dopamine, Methadose, and different class, and I'll talk a little bit about that in a moment. Buprenorphine, it comes in transmucosal pills and films. Those are the kind that you can just put in your mouth and they just absorb, subcutaneous and injectable under the skin types. And again, they come with different brand names. And then Naltrexone, which comes in a pill form as well as an injectable form. And you can see from this table, it kind of tells it all in terms of how they work. And so this might be something to refer back to at different points. So the medications work differently. And, again, how much science is necessary to understand is a little bit up to individuals in terms of what they want to learn. And it is complicated, but part of the reason we try and teach that is because when medications are in trying to combat the stigma of using medications to treat opioid use disorder, a lot of people have been working really hard to educate the public because these medicines do work on the opioid receptor. And so if you look at this picture, this is the opioid receptor. The opioid receptor is what is implicated when that dopamine release, that pleasure release first hits. And so methadone and buprenorphine are medications that work through the opioid receptor, and they could be used as medications that contribute to opioid use disorder. So it's really confusing to say, how can a medicine that can contribute the disorder also be used to treat the disorder? And it's really important to understand that under proper medical supervision by a prescriber, these medicines can actually treat the disorder. So we want to combat the stigma that has been long associated with these medications to help people understand that, again, if you understand these reward pathways, what we really need to do is treat the receptors so that we don't have these downstream problems with the brain changes that I was describing before. So methadone is actually the oldest and most tried and true medication to treat opioid use disorder. It's what we call a full agonist. It essentially goes in and goes into that receptor in a way, the same way that, for example, heroin or other opioids would go into the receptor and achieve that same effect. But what it does is it's a very strong agonist, and so it would block other types of medications from coming in and having, or other kinds of drugs from coming in and having that effect. Buprenorphine is a partial agonist, which limits the effect of other drugs that people might be using, and contributes to the ability to control the sensations that people are getting from taking these off-label or off-prescription or drugs that people are getting on the street. And then naltrexone has a completely different property. Naltrexone actually blocks that receptor, so that when somebody takes a drug like heroin or fentanyl, naltrexone will block the sensation. But actually what naltrexone does is it'll reduce some of the cravings associated, so people potentially won't want the medication or the drug to begin with. Whereas these other ones have an effect of actually being what we call an agonist that generates the effect, but in a controlled manner. And again, methadone is really the most tried and true medication. Again, it binds to opioid receptors. It mimics the opioid effects and therefore blocks other opioids. It will reduce cravings. It will reduce withdrawal, and it will reduce the cues and triggers associated with seeing opioids. It's taken daily. It's available in a pill, liquid, and wafer forms. And what is important is know what we call withdrawal period, or the old word was detox. We try and use the word withdrawal now, is really needed to begin to use methadone. One of the challenges with methadone is that it's heavily regulated because it does have powerful effects. It's regulated and can only be prescribed for opioid use disorder in what's called an opioid treatment program. Now, interestingly, methadone is used to treat pain, and you can get methadone to treat pain in a regular primary care clinic. It's not regulated when it's being used in a controlled way to treat pain. But when you're treating opioid use disorder, it has to be prescribed in an OTP, an opioid treatment program. And so that is one of the issues that can be a challenge for people who are on methadone, because you have to go to that clinic and there's heavily regulated rules about dosing and whether you have to show up every day. Initially, you have to show up every day. And once you've achieved some stability, you can get take-home medicines under a regulated schedule. And there's federal regulations, and then there's state regulations as well. And so for some people, showing up every day is actually really helpful. And for other people, that can be more of a challenge. And so when we think about what's going to work for people, we have to think about how do they access the care. What does the research show? The research is really positive about methadone. It lower doses and shorter treatment periods were less successful than higher doses and longer treatment. But once people were on the right dose for several months to a year, people will have lower recidivism risk, and they will engage in fewer risk behaviors like needle sharing and unsafe sex that present other risks associated with opioid use disorder. So it is a very effective medication. Unfortunately, methadone was associated with a lot of stigma. The old term methadone clinics were associated with a lot of stigma. And so we try and not we try not to use some of those terms. That's why one of the advantages of calling it an opioid treatment program is really to try and move past some of the stigmatizing images that were associated with the prior term of methadone clinic. It is a very, again, effective medication, the oldest one, tried and true. Again, the pros are it improves treatment retention, it reduces heroin use, crime, mortality, and HIV risky behavior. It's very safe for pregnant women. It lasts for at least 24 hours, which is why you only need daily dosing. There's no legal limit on how many patients an opioid treatment program can treat. There's no ceiling effect, so doses can be increased as the patient becomes tolerant. It is a challenge sometimes to find the right dosing. Sometimes people who are being dosed might become sleepy. That's a sign that they're overdosed, so you can lower the dose, and that's part of the clinical art of working with the patient to make sure the dosing is right. The cons, it's possible to continue to use illicit opioids while on methadone, especially if the dosing is not high enough. And so it's important to get that balance, because usually when people are using illicit opioids while on methadone, it means that we haven't agonized the receptor sufficiently. And so we have to adjust the dosing. And that is very individualized. Someday maybe we'll have genetics, which will tell us exactly which medicine is the best and what dose is right, but we're not there yet. So we have to do it based on clinical judgment and reporting from the patient and maybe other observers. Methadone, again, follows a strict protocol, again, which makes some people feel that they have no control over their treatment. And it does show up in some urine testing for employment. And again, the daily visits to the opioid treatment program can be difficult, especially when traveling a great distance. And there's not opioid treatment programs across the state of Michigan. That is something we are looking at, how to expand access to these OTPs. Buprenorphine, let me talk a little bit about the basics. Again, it's a partial agonist. It binds to opioid receptors and also mimics opioid effects. It partly blocks and partly activates those receptors. It protects, it's often combined with the antidote, which is naloxone. The formula in the prescribed version can also protect against overdose and intoxication because of that. It treats cravings and withdrawal. It usually is in a pill or film version, although now there's an implant that can be inserted beneath the skin every 6 months. And there's long-acting injectables available that last weekly or monthly. And so, so those are important to think about the different ways it can be prescribed and delivered to the patient. Now, what's important about buprenorphine is because of the way it works, the patient has to be 24 to 36 hours outside of their last opioid use. And they have to be in some state of withdrawal to begin to treat with this medication. Also, it requires a special certification for the prescribers, and prescribers right now, the way the regulations work, can only prescribe to a certain number of patients. Patients on doses of buprenorphine of 16 milligrams per day or more were likely to stay in treatment. Again, it's maybe counterintuitive to people to hear that you need to dose at higher levels to keep people in treatment, but that is, again, the art that we have to, if we underdose, we risk people going out to the street and using illicitly, because essentially they're trying to treat the issues that are going on with their neuroreceptors. We know that with buprenorphine, we can decrease the number of opioid positive drug tests we can from illicit use. And the majority of those who used illicit buprenorphine, again, reported that they used it to reduce withdrawal symptoms and reduce cravings, which means that it wasn't dosed probably sufficiently. The pros are there's less monitoring than with an opioid treatment program. It's available through primary care. Any prescriber who has what we call the X waiver on their license to prescribe can prescribe this in an outpatient setting. It doesn't require the patient to come back every day. It does lower mortality, just like methadone. The cons are it still is divertible. Again, prescribers need specific waivers. You have to go through a withdrawal period that sometimes is intolerable for people because of the pain and discomfort associated with it. And so it may not be the best choice for all people. It is also, one of the other pros is it is also used in pregnancy. Naltrexone is the third type of medication, and this is the pure antagonist, which means it binds to the opioid receptors and blocks them completely, and it prevents the binding of other opioids. There is an oral formulation in pill that it can be taken daily. It should be taken daily if it's prescribed. And then there's the extended release injectable version that's used on a monthly basis. And it can be taken, but only after 3 to 10 days after the last opioid use. It's not really indicated to give naltrexone while somebody is still actively using. So if somebody's actively using, they have to be sort of free of opioid use for a period of time. So that can be a challenge. Any prescriber can give this for any number of patients. It's not more regulated than any other medication that's FDA approved. Now, people might note that the camera just went out of focus. Just want to point that out. Sure, people watching that might make them dizzy, unless it's my vision. Anyway, what does the research show? Extended release injectable naltrexone can be more effective than oral naltrexone in increasing abstinence and treatment retention and reducing cravings. The effect of extended release naltrexone has been established when used in conjunction with behavioral health supports. However, we also want to be aware that in a lot of correctional facilities have moved towards injectable naltrexone. And it was an important step forward, but we don't want to lose sight of the fact that buprenorphine and methadone may be still better for some people, again, depending on what their needs are, depending on their current situation. And that one of the challenges with naltrexone is sustaining people on treatment long-term. The studies that are looked at often don't follow people out for years, and there are some risks of people stopping even the injectable version, the injection. The cons are the injection can be uncomfortable. It can be hard to sustain. And so we see a lot of people who go get their first dose upon release, but then might not sustain the treatment in their monthly injection after 1 or 2 doses. And so it's really important if somebody's on this medicine that we provide them the supports to continue to receive those injections on a monthly basis. It can prevent overdose and intoxication. It can reduce cravings. Again, it can improve treatment retention, and that's always important. The cons are if the person does relapse, there's going to be lower tolerance, which potentially will put people at risk of dying. And again, people have to wait till they're opioid free before you initiate treatment. And otherwise you could precipitate a withdrawal, again, because you're blocking that receptor so firmly. Now, another medicine that I want to point out is not a treatment to directly treat opioid use disorder, but it's a very important support medication that is used to support individuals with opioid use disorder. And that is naloxone, also known as Narcan. And it's sometimes confusing between naltrexone and naloxone to remember those. But you can remember it because naloxone has 2 O's, and you can think about opioid overdose prevention. It is an opioid antagonist, and it reverses opioid overdose by attaching to the same brain receptor, but more strongly. So it can knock It can knock opioids off. If somebody has overdose, it kicks the opioids off the receptor and takes over the receptor with the onset of action 1 to 3 minutes, and it's given intranasally or injective or by injection. And there's no risk if given in the absence of opioids. So if you have somebody that's passed out and you don't know why they've passed out, giving naloxone won't hurt them if they were passed out for other reasons. But if they were passed out and potentially at risk of stopping breathing and death because of an opioid overdose, this is a life-saving medication. So oftentimes with somebody who's got opioid use disorder, the prescribers are co-prescribing naloxone with any one of those other 3 medications to deal with an overdose. And not only for the person who's got the opioid use disorder, but there's also the issue of making sure that people surrounding that person have naloxone available. Because obviously if the person overdoses, they're not going to be able to administer the naloxone themselves. So is MOUD effective for people in the criminal legal system? And the answer is yes. Evidence shows that all of these do reduce opioid use disorder, and they reduce the overdose risk, and they improve treatment retention. They improve withdrawal and cravings. And they also, by being in treatment, can reduce the risk of collateral consequences of opioid use disorder, including the risk of infectious disease, as well as the risk of criminal activity associated with drug use. But each medicine has its pros and has its cons. And there's no one medicine that's perfect for all people. And so we want to be careful as people are coming out of the criminal legal environments like correctional facilities that we don't just use one medicine as if that is the fix to the opioid crisis. We want to make sure that all medications are available to people both going in and coming out of the correctional environment to maximize the ability for people to stay in treatment. And this is a slide that shows that between methadone and buprenorphine, there are studies that show reduction in heroin-related deaths. So the question might be, well, which medication is best for my client or for the parolee that I'm supervising? How do I know what's going to work for them? And I think it's really important to realize that the effectiveness of medications is reduced significantly when programs override the patient wishes and change a medicine that had been working. So number one is we want to be person-centered in our thinking. We also know that there's the drug use outcomes can be similarly positive between these 3 medications, but there can be But the issue of how long they stay on treatment might be different, whether they experienced other kinds of problems while they were on treatment can be different. And so they're not 100% interchangeable. You can't just say one is equal to the other. The other thing that's really important to realize is that this is not a ladder type of initiative. It's not some people had the belief that we start everybody with naltrexone. If they relapse, we move to buprenorphine. If they relapse, we move to methadone, as if methadone is the last resort because of its only being prescribed in the OTPs. We have to get away from that thinking. There is no evidence to suggest that you have to go stepwise through each of these medications to achieve success. So you could have somebody who comes into the opioid treatment program for the first time, and methadone is exactly the right medicine for them. Or you could have somebody that naltrexone is exactly the right medicine for. So we want to make sure that we understand that these are medicines that can have positive impact, but they work differently, and there's pros and cons to each. And we have to assess their medical, psychiatric, addiction history. We have to understand the treatment setting that's going to be most available to them, transportation to get there, if there's restrictions that are imposed upon them, that can be an issue. We're trying to knock down those barriers, but that can still be an issue. There can be outside attitudes of families, friends who say, we think this is better. This is a better approach. We think abstinence is better. We think this medicine is better. We do know that these medicines over time are more likely to succeed, help people succeed and live longer, healthier lives than abstinence-based care. And so we really are trying to move away in the medical field from thinking about detox and moving to withdrawal management, which might include withdrawal and transition to a medication. And it might be an immediate transition, for example, to methadone. It might be a transition in 24 to 36 hours to Suboxone. It might be working with the person over a period of time to get to that 10 days of non-use to then be on Naltrexone. And so we really want to think about withdrawal management as the way to safely move people from opioid use disorder to being treated with medications for the disorder. And these are really important things for the prescriber to be discussing with the patient. And it's very important that we get more knowledge out to the lay public, to parole officers, probation officers, courts, anyone who might be interacting with the individual, so that the same message comes across in all settings. Side effects and drug interactions, important. We do see in many of the overdose deaths the finding of benzodiazepines. These are sedative types of medications. They're both prescribed and they do get used on the streets to often to deal with some anxiety symptoms, but they do have addicting properties. And we often see these with people that died, that there's both opioids and benzodiazepines in the system. There are some studies that suggest that when benzodiazepines are prescribed, that the risk of death with that is less. And so the concern is really when they're not prescribed and they're used on the street. So there can be legitimate reasons to prescribe benzodiazepines. However, there is a known risk involved in doing that, and specialists should be involved in that. Health status, again, pregnancy is a really important issue to think about. Buprenorphine and methadone are tried and true. What we don't want is to treat somebody during pregnancy with those medicines, and then as soon as the baby is delivered, take the mother off those medicines. That puts the mother at greater risk of death. And unfortunately, we're seeing higher risks of deaths among pregnant and recently women who've recently born a child because of some of the transitions in care that occur. Liver failure is another issue we have to be mindful of, particularly with naltrexone, which can interact more significantly with the liver. And the liver is an organ in the body that's can be particularly fragile, especially if somebody has something like hepatitis, which unfortunately often co-occurs with opioid use disorder because of some of the risk-taking behavior that the patients are involved in. Side effects of these medicines can include drowsiness, discoordination, new physical symptoms, even withdrawal symptoms. And where you see those side effects, it might mean a checkup is necessary to get that dosing right and to make sure that that person is not using other substances that can contribute to some of the challenges. It's important to also realize that there are co-occurring psychiatric conditions and medical conditions with opioid use disorder and other co-occurring substance use conditions. So things like depression with and without suicidal thoughts, high risk area, anxiety, trauma-related symptoms, etc. For medical conditions, hepatitis, both A and C, HIV, endocarditis, which is an infection around the heart, pain conditions, a very complex area because some of the pain treatments historically have been opioids. And so working with somebody with a pain condition is going to be really important that we have specialists involved. And then other substance use disorders, in particular, we're seeing a lot with methamphetamines, cocaine, and then we can't ignore alcohol. And actually, in terms of the sequelae on children, one of the most risky substances for babies being exposed in utero is going to be related to alcohol. So it's important to realize that medications to treat some of these other conditions might be necessary. So an individual is going to be potentially on a few different medications, and these can be safely prescribed. So for example, when I was in training, we were taught treat the substance use disorder and then the depression. Now we don't think that way. We treat both simultaneously. So somebody might be on an antidepressant at the same time that they're on buprenorphine. Same with primary health conditions, treating that hepatitis, getting out in front of the health conditions is going to be really important to stay on top of the substance use disorder. Now, what about the duration of medications? A lot of people say, okay, I was on it for 6 months, that should be enough. People may take medication safely and effectively for months, years, and even a lifetime. Research shows that individuals should be free from substances and stable in mental health and general health, address their vocational educational needs, and have a supportive family situation for 1 to 2 years before tapering off methadone or buprenorphine. And some people would say maybe you shouldn't even taper off at all. There's a lot to learn from that. One of our hardest challenges, besides getting people on these medications, is getting people who stay on these medications. So we're trying to do a lot of work at the state to understand retention and care. But the data for chronic disease is really that sometimes you need to be on medicines for a long time and sometimes for a lifetime. Naltrexone right now, the data showing it's recommended for at least 1 year. Some have taken it for 5 years or more with no negative effects. But again, since we don't have great data on long-term, we're going to need to learn more about it. And right now, the message to patients should be 1 day at a time and not, we'll taper you off quickly. That would be a high-risk thing to do. Barriers can be the availability of providers in the community, limited availability still within jails and prisons, although there was a press release just today with Governor Whitmer announcing and the Department of Correction under Director Washington's leadership that the prison system has a strategy for introducing medications into the prison population, medications to treat opioid use disorder, piloting it across 3 facilities and then moving it beyond that. There's many jails that are embarking on this as well, so that ideally we'll have seamless care, whether somebody is out in the community, in a correctional environment, and then back out into the community. Again, the barriers can be misconceptions. We've worked really hard with parole and probation, and the policy within the Department of Correction was shifted to say that if somebody's on proper prescribed medication, that would not be a reason for a violation of their parole or probation. Barriers can include housing restrictions and then, of course, stigma, which is something we really have to combat, not only from professionals, but from the individual themselves who may feel like it's a weakness to take a medication. And we have to combat that stigma from family, friends, the recovery community, and providers. Best practices for treatment in the criminal legal system is begin treatment during incarceration, plan for treatment in the community. The American Society of Addiction Medicine has said all adjudicated individuals, regardless of the type of offense and disposition, should consider and be considered for the initiation or continuation of medication for the treatment of opioid use disorder. For incarcerated individuals, it should be initiated a minimum of 30 days before release, and aftercare should be arranged in advance. And I think we're bumping that up from 30 days to upon arrival. There should be no disruption in care. And the National Commission on Correctional Health Care has also weighed in, saying starting MOUD during incarceration versus post-release leads to better treatment retention. We've been working very hard in our Mission Criminal Justice Project to develop a reentry checklist that supports the APIC model of reentry, which is looking at, and we're going to be rolling out across the Department of Correction facilities, which really is sort of saying, did I do what I needed to do to make sure that the connections between the treatment team within the facility, parole and probation, the treatment providers out in the community, who's ever prescribing the medication to treat that opioid use disorder, the payers, through whether it's through the PIHPs or the community provider network, are linked together to make sure that that individual not only has sustained treatment, linkages to treatment, but also that naloxone that's so critical to avoid opioid overdose upon release. We need to support medication adherence, assisting clients with follow-up appointments, being empathic and understanding about the demands involved with medications. I mean, all of us who've been prescribed any medication know that it's kind of a pain in the neck to take a prescribed medication, and we all want to be healthy and not need medications. So we have to be able to understand the demands involved, help people express their views. Remember, a lot of the population we serve have trauma histories. Assertiveness might be difficult. Self-esteem issues might be challenging. Feeling those resiliency variables might feel weakened. And so we have to help people build their resiliencies and express their views. We also want to help identify breakthrough symptoms and risks for relapse. And of course, treat co-occurring mental health conditions and medical conditions and facilitate access to all types of treatment needed. We want to work to monitor appropriate use of medications through collaboration, through peers, recovery coaches, and others to ensure that medication is being taken as prescribed. And that requires cross-system treatment team coordination and planning, appropriate use of drug screens, watching for signs and symptoms of use, and really open communication between client and staff. This is nothing to be embarrassed about. This is something we should just be talking about. If we notice somebody nodding off, we should comment on it. We should say, this could be a sign that your dosing isn't right, or that we need to, or that there may be some other use going on that we need to address, and being honest about that. So that is the presentation for today. We do have time. I don't know how much time. We do have time for questions and answers if there are any that people have. Okay, how can jails or prisons deal with the concerns about diversion of medications? So this is a real issue. And it's not fair to just say, everybody should just totally be on board and there's zero risks of diversion. And I mean, obviously this has been a concern, and these medicines do get diverted. I would say there's a couple of things to think about. Number one is, diversion to who? If the medicines are being diverted, then there's somebody who's using them. And if somebody's using them, why are they using them? It could be that they're using them, again, because they're trying to treat their own receptors. They're trying to dose themselves in a way that helps them get themselves out of that disrupted reward pathway. So the first question is, if somebody is using in a correctional setting over what's been prescribed, and of course currently there's not a lot of jails and prisons that are where you can actually get these medicines prescribed, we want to understand maybe we need to treat the disease, and then the person won't try and treat themselves. There's also the issue of who's doing the diversion. What's going on with them? Is there secondary gain? What are the issues? Obviously there's people with malintent that want to make money for their own needs. But sometimes people want to make money for their own needs because some of their own needs aren't being met. Not everybody. Some people do need to be sanctioned, of course. That is the way our legal system works, and we haven't solved the problem to not sanction some people who are doing the diversion. But sometimes there's other needs that aren't being met. And so when we think about jails and prisons, a lot of them are looking at, what does our environment look like that could potentially be more trauma informed, that could potentially help meet some of the needs that aren't being met. And then, of course, appropriately using sanctions. I heard about one program where they were really working on this sanctions within the correctional system in a really creative way to think about sort of getting ahead of the issue like we do in the community now, like we do with drug courts, for example, to understand what's the behavior, what's driving the behavior. Maybe they're using too, maybe they're using other substances. And so there's something going on that could be treated there. And I don't mean to be an apologist. I'm not trying to be an apologist. I've worked in too many correctional facilities to know that we can't totally apologize away all behavior, but we do need to understand behavior, because what our system's doing right now isn't quite working to treat this. It's certainly not working to treat this crisis. And I think we can be creative and push the envelope a little bit to understand that a little bit more. Another question that came in is, if methadone is an opioid, isn't it just as bad as heroin? So again, you know, in some countries, heroin is used to treat opioid use disorder. It's used under really controlled conditions. In this, it's not a practical medicine to treat opioid use disorder because to dose it, you would actually need to dose it the way people use it on the street. You'd have to dose it every couple of hours. That's not practical, and there's other problems with that. In this country and elsewhere in the world, methadone is used to treat because, again, what you're doing is using the property of the medicine to get ahead of that reward pathway as the agonist that affects that receptor. And the practical aspect of methadone, the effectiveness of methadone, is that it really only needs to be dosed once a day if it's dosed right. And then people can really live a really functional life without the cravings, without the risk of all the negative consequences. They can have jobs, be professionals, whatever they want. I mean, it's really a remarkable, when you see people achieve recovery with methadone or with any of these medications, it's really can be remarkable. So even though it is an opioid, it's an opioid that can be used with a prescription in a way that treats the disease itself. Okay, a couple other questions came in. How do we educate probation parole agents who administer drug screen tests as part of a sentence condition? Well, it is still important for parole and probation to manage the public safety interests of our society. They have a very important function in that regard. And the drug screening tests can also detect illicit substance use. And that's important. So there's levels of testing that can help determine whether a substance is used illicitly or it's a substance that's used as prescribed. And so the question is, working with parole and probation and some of the new policies that are coming out of DOC to understand what's that drug screen test being used for and what is the repercussion, if any, of what comes out as a positive. And so this is an evolving area. And again, the Michigan Department of Correction is working hard on shaping those policies. And there's probably a lot more training that can be done to understand that and doing, some case examples of what happens when this test comes out positive in this way. Clearly, if somebody tests positive for cocaine, that's not going to be what would we see if somebody's being prescribed buprenorphine, for example. So that means there's something else going on for that individual. What is the status of state and federal laws mandating medication for opioid use disorder services in correction settings? Well, that's a really evolving landscape. There is litigation, meaning lawsuits, against certain correctional facilities for failure to prescribe these medications. Usually those lawsuits are based on the idea that the constitutional right of people that are incarcerated to treatment. And it is the only group of people in America that are constitutionally given the right to treatment are people that are confined to correctional facilities because they don't have any other access. And there's case law on that. And so essentially their right to treatment is supposed to be the same level of care that's available in the community. Now, of course, we have problems with access in the community as well. But some of the facilities, the correctional facilities, are facing litigation or scrutiny related to not providing that care. So it's not necessarily that laws are changing, it's that civil liberties of folks and civil rights attorneys and people with lived experience are basically saying, I want my treatment regardless of whether I'm incarcerated or not. And that's good because it pushes the system forward. There is a lot of work to be done. It's not so easy to implement. That's the only thing. It's not going to be an overnight fix, just like it's not an overnight fix even in the community. We have challenges to get prescribers appropriately trained to prescribe. We don't have enough addiction specialists in society. We're working hard at the Michigan Department of Health and Human Services to expand the workforce. And there's a number of initiatives to expand the workforce and develop trainings, for example, a training like this. So there's a lot of work to do both outside of correctional facilities and inside of correctional facilities. But that's essentially what's happening. There may be some laws that come around also that will help. For example, there is some thought about potentially being able to have Medicaid funding reentry services with InReach. That's not specific to the medications, but that could sort of start to think about what happens at that interface. And so, we're watching the federal laws. There's also potentially some federal laws that could change regarding how these medicines are regulated. There is some advocacy about deregulating, making it easier to get access to these medications instead of having like this X waiver, a special certification. There's some people that are promoting the X, and we'll see. I don't know where the world will go with that. It's hard to predict, but there are different pushes and pulls in those directions. One individual asks, is there a difference between buprenorphine and Suboxone beyond generic and brand name? Suboxone is combined buprenorphine and naloxone. And so that is a difference. So some of the preparations will have both the buprenorphine, which treats that receptor, as well as that naloxone, which prevents overdose. And so Subutex, for example, is just buprenorphine alone. And so there's different research coming out about whether that naloxone prevents the original thinking. And some of the research suggests that if you prescribe the Suboxone as a buprenorphine naloxone combination, you reduce the risk of overdose because you have that medicine that prevents that overdose embedded into the medication. It's like combined in the formula of that medication. And so that is one of the differences. Oh, this is a great question they're pointing out to me. If we provide Narcan, doesn't that just encourage people to continue to use? That is such a fascinating issue. Some people would say if we provide Narcan and people feel like, well, I'll just get rescued. And you hear about things like Lazarus parties where people use and then have somebody ready to rescue and then use more. And so that's some of the thinking about, are we just promoting use and people believing that they can be infallible and use and not risk dying? I would say that our death rates tell us that people are dying and that it is better to have naloxone available to rescue an individual and then to work on not just giving that naloxone, but recommending that and trying to get that person into treatment after the rescue. That's really important. It's not just about rescue. It's about rescue and referral as much as possible. So training EMS, training emergency staff, training public, training everyone who's got naloxone to say it's not just about the naloxone, it's naloxone and referral to treatment. We know that people, again, as I said in the very beginning, will engage in extremely risky behaviors because of this problem with their reward pathway and the avoidance of that negative effect that happens in their brain. And so it doesn't make logical sense to a lot of us who haven't had this challenge to why somebody would use again after they almost died. But it tells you how bad the disease is. So I would say we got to keep prescribing naloxone and we got to rescue and refer. Another question just came in. We have grant funding to cover medication inside the jail, but what are some options after the funding ends and how do we sustain medications for opioid use disorder? Well, I tend to be a hopeful person and think positively. These grants hopefully will help us see that by treating these diseases and by reducing recidivism, we'll actually have fewer people coming into the jails by promoting not diversion of substances, but criminal justice diversion from incarceration and diversion from arrest. We'll have less need for it in the jail, which hopefully will then cause some result in some cost savings that eventually will catch up so that the provision of these medications will be easier to be able to afford because we'll have fewer people who actually are coming in and out of the prison and jail setting. That's kind of like a big picture, long term, not now, but years ahead, hope for our society. Because if you look at the data on the correctional populations and how many people have substance use disorder in our correctional system, you'll see that we have been incarcerating our way out of drug problems, and that's not working. So again, hopefully with treatment and more medical science, because we don't know what medications are going to be approved coming down, in the future. We'll have more medications available, more will go generic, there'll be cost savings. So there's all sorts of things that are coming down to hopefully be able to sustain the treatments that are going on. There's also going to be the mandates, through litigation and potentially through some of these federal things that are happening, that will make it so that, just like with other treatments, it's not going to really be a choice. If somebody has an illness in jail, you have to treat it. And that is kind of how it's going to play out. So funding is something we have to pay attention to. And certainly at the state, we're watching that. The long view is far away. And so we'll have to pay attention to more to think about, how to keep these services going in the meantime. One more question, I think. One more slide. Okay. So wrap up and next steps. Again, this session was recorded for those who couldn't attend. When the link becomes available, it'll be distributed. Please complete the evaluation to help us determine additional training needs. It's really helpful to get your feedback on how the message was delivered, what more you want to learn on this topic or any related topic. So I want to thank you all very much for signing into this webinar. I want to thank you for your attention. And I really want to thank the Center for Behavioral Health and Justice for giving me the opportunity to present on such an important matter that means a great deal to me on a personal and professional level. So thank you.